Hello, everyone. It gives me great pleasure to be here today. And we had just such an amazing discussion as we moved to this panel. Just to comment on that, COVID-19 has completely changed our lives. And when we thought that, things would be just taking steps to proceed, it took us a decade ahead in many ways. Not only has it been breaking silos between public and private healthcare, but it has also changed the shape of leadership, and empathy has taken a new shape and new admiration for everyone. But not only that, one really interesting thing about COVID-19 is that it's also reshaped our thinking. It's redesigned the way we think about healthcare and how we need to use data. Data has always been termed as the new oil in this day and age, but it's much more beyond that. And now we need it as a mode of survival, a mode of investing in healthy people, finding cures, and much more. And today we have a set of two really interesting panelists to have a discussion with us today on how data has reshaped our thinking and how are we redesigning the use of data in healthcare. We have Dr. Elizabeth Robilotti with us, who's an expert in, my apologies if I didn't pronounce that correctly, who's a specialist in infectious disease specialist from Memorial Sloan Kettering School, from the Cancer Center in the US. And then we have Dr. Charles Allessi, the Chief Clinical Officer at HIMSS. I'm going to start with Dr. Elizabeth. I've had a really interesting discussions with her, and they have really been using data in a different way with the start of this pandemic. And I'd like for her to just talk to us initially about how did data, the existing patient care data, transform the way when
Dr. Hashmi, I think you went on mute again. Can you please verify on your part?
Can you hear me?
Now we can.
Okay.
Yeah, yes, I can now.
I think I got the last part of the question. Good morning, everyone, or good afternoon, depending on where you are. Good evening for some, I think. It's really my great pleasure to be joining this panel, and thank you, Hassan, for the invitation. The COVID-19, as everyone has noted, has been an unprecedented event occurring at a time when we usually feel very confident in the amount of data we can generate about patients. But unlike a lot of other scenarios, the pace at which we had to interpret that data and potentially modify the things that we're used to collecting really changed the way we looked at patient care. And here at MSK, where I'm one of the infectious diseases doctors, we were just so fortunate to have a really robust infrastructure for patient care data that has been utilized for years in the analysis of cancer and outcomes and even prediction. But it wasn't really perfectly tuned to infectious diseases, which move at a different pace. So one of the things that we really focused on in the beginning of the pandemic, hearing the reports as early as January out of China, and we started anticipating what the impact would be for our patients. But it wasn't really until March when we started seeing our first cases in New York City that we could even start knowing what data we needed and how we would be able to collect that. So one of the things that we were really fortunate to do was leverage our electronic health record to be able to, in parallel with the clinician's direct experience, create extraction tools to help us predict what kind of symptoms people would be coming into the hospital with. Were the symptoms in cancer patients who may already be on oxygen or have fevers for related to therapy or because of their primary disease? Were all of these things going to still be true in our cancer patient population? And so as the epidemic curve took off in New York in March and April, we tracked our own patients and were able to extract symptoms that we used for prediction of who would get admitted, as well as factors that were related to severe outcomes. And this, the difference, I think, and the sort of mental flexibility that we needed here was that the outcomes are usually longer term in cancer when we're looking at them. And for infectious diseases, we're looking at a 30-day outcome and even in some cases, a 7-day mortality rate. We then were able to look longer at the 30-day outcome rate. And this would not have been possible without the existing infrastructure and the collaboration of a lot of clinicians with eyes on patients who were giving us great keys to which data elements we really needed to focus on.
If I may, Dr. Elizabeth, how did this data tracking visualization inform the policy changes? Did they impact it at all? Yeah,
so, we were creating policies for a lot of different avenues. So the first, we had to both make sure our staff was safe and make sure our patients were safe. And the way that those two connected is actually through contact tracing. So everybody who's familiar with or experienced COVID-19 is familiar with the test, trace, isolate mantra, which is basically how you can extinguish an infectious diseases outbreak. And for us, we had to create a bunch of policies around personal protective equipment, on access for staff to different parts of the hospital. And, we were doing this, as a few of the speakers have already noted, in a setting of scarce resources for some really essential items. So we had to figure out, how's our policy, if we adopt universal masking policy, universal face shield policy, how many staff does that actually mean we can have seeing patients face to face based on how many masks we have coming in the door? We were very fortunate that we weren't faced with some of the shortages that a lot of other institutions and global communities faced. And I count myself incredibly privileged to have been in that setting, but it doesn't mean that we weren't using data to help us anticipate that. So we were able to design our infection control policies around those models of how many patients would we have coming in the door, how many staff would we have taking care of them, how much PPE would they need, and how much PPE do we have, which informed a lot of what we did with staff policy and provided a lot of confidence, I think, to our staff to say that we have this to protect you. On the patient side, it was, a totally different approach where, we had to really ramp down our clinical operations of cancer care right when the epidemic was hitting. And that, was really a balancing act because, cancer, like several other health conditions, one really good parallel is pregnancy. Cancer and pregnancy, they don't wait just because we're having a pandemic. And so we had to really figure out, with the data that we're analyzing, how could we continue to provide care for those patients who are in the critical phases of their illness, but also lead to the least disruption of care for the other patients who could afford to delay for a period of time, but not indefinitely, obviously. So my colleagues in the Department of Surgery spent an enormous amount of time looking at this and using their data about OR times and capacity to basically model, if we have to turn so many ORs into ICUs for COVID patients, how can we still continue to provide the immediate care that we need to patients with surgical emergencies or tumors that can't wait? And that they really did an amazing job figuring out how how to transition and navigate through that period of interruption. But back to contact tracing, which is where the staff and the patients match. This has been really, I think, one of the most exciting areas for use of data and development of innovative systems to use data. You know, these aspects of the hospital were previously sort of siloed and really only met through infection control. So employee health was one really separate segment of the hospital, and then, you know, patient care was on the other side. And we have now developed an integrated system whereby we can track any symptoms that develop in staff and connect that temporally and spatially with any patients who may have been COVID positive, or vice versa. If there's a staff member that we find out about who has become COVID positive, we can feed that back into systems to help understand what patients may have been exposed. Of course, we assume everyone is using their PPE perfectly, so there's no exposure, but we now have been able to marry what previously had been very separate processes into one integrated system to provide safe care.
So just going to the point on management, so talk about, you know, there was this very huge role that COVID was playing in terms of expediting the way management is working and how it's been revolutionized through this pandemic. And you talked about managing COVID patients and cancer patients simultaneously, and what a challenge that has been. What role did predictive data modeling play in this, and did this help at all?
Yeah, so that was a very, so there are a lot of modelers at MSK who do various types of modeling, mostly around cancer, but also around management. And, you know, we can't stress enough how both the PPE issues presented a challenge in terms of how we would predict how to take care of patients. But another very important issue that we haven't yet discussed is testing supply shortages. And, you know, most of the other outbreaks I've ever been involved in, we design a test, we have a test, we use that test as much as we want, and we can use that to identify patients or staff who are ill. One of the challenges with COVID has been, first, it was a shortage of swabs to actually be able to collect samples. So we did a lot of different things around that, including expanding the sample types you could use to test. And then after that, there's the next challenge of reagent supplies. And that, you know, led to a lot of different decisions about how to maximize the number of tests one could perform without, with the least use of reagents. And I have to commend our microbiology staff. They have done an amazing job under the leadership of our clinical microbiology director, Dr. Esther Babity, of scaling up testing. And this was enabled in part by being able to predict how many patients we would have coming in. And we then designed sort of what was our optimal testing strategy. So we want patients who need to come in for a procedure to get tested before their procedure. If they end up admitted, we want them to get tested on a serial level to make sure that there's no development of infection while they're admitted, which could put other patients or themselves or staff at risk. And we also needed to factor in, will we test people as a test of cure? So all of these kind of machinations of how to do testing were put into models of what is our testing capacity so that we could best design appropriate policies. And then we use that data to sort of to navigate around shortages of different spots. So if we presume that we needed a certain amount of tests to be performed for a census of 80%, we could then anticipate what census we could continue to test robustly without if we were restricted in terms of reagents. So it's been really amazing to watch how all these different data elements work together in what had previously been very disparate parts of the institution, and everybody's really come together to figure out how to continue to provide great care for cancer patients.
Great. Well, thank you for that. I'm going to move to Dr. Charles. And just with the initial question, I'm not sure how much of it was on mute and how much you could hear me, but how did the current existing data that you have at HIMSS, how did that get transformed during the commencement of this pandemic? What did you reuse? What happened? What are your learnings from that?
Thank you. And thank you very much for inviting me to speak at this conference. I'm deeply honored. You know, HIMSS, with its global perspective, has the ability to not only achieve its vision, which is really to realize the full health potential of every human being everywhere, but it does that in a way whereby it has exposure to what's happening globally. And I think it would be worthwhile just trailing back a second and thinking in all the conversations that I've been having since the beginning of January with most of the countries in the world, what are the lessons? What are the real tangible aspects that come out of these conversations? And then move to data. And some things are really abundantly clear. There is a significant difference in the way that countries in the Far East in particular dealt with this pandemic, which largely outpaced the ability of health systems everywhere to cope with it. And it's very interesting and really quite educative speaking to people from everywhere from Japan to Thailand to Singapore to South Korea around the way they approach this. They approach this very much like it was one of those coronaviruses that they knew so well. This was another SARS. This was another MERS. This could well be a type of H1N1. You know, to the degree that all their policies were based around the fact that we really need to manage this very, very, very carefully. And that, to a degree, is a little bit different to the way the rest of the world approached this, which is really more like this is a particularly virulent type of a pandemic flu. And the two approaches have really quite significant connotations in terms of the approach. So that's, I think, the first lesson. The second is really looking at the effect and approach of the nations and the response of the population. People who have had a significant degree of not necessarily political instability, but natural disasters. And I go to Japan, of course, with all the earthquakes, with the nuclear problems they've had. People who've got a history of a really active civil program in terms of managing populations and doing it very rapidly and doing it very recently have done really well. Japan suddenly turned on its system of very local public health like you're flicking a switch. It was quite remarkable to watch. And of course, there is a big difference between little countries like Singapore, that is obviously a place we all look to in terms of their ability to actually manage everything really quite remarkably well. But I mean, it's so small, it's a city-state, to a large country. And places that have had this history, and it's not necessarily have had the infrastructure, because lots of countries in Europe have the infrastructure, but because it hasn't been used recently, it somehow doesn't work quite as well. This is similar, I think, to running in a motor car like we used to years ago. Things sort of work better if they do. So I think that's the second sort of approach. And now we think in terms of the lessons associated with the use of data, which is really what you asked me. And people like me have occasionally been accused of over-promising and under-delivering digital transformation. And to a degree, there's an element of truth in that. I have always felt, certainly over the last couple of years, but actually I could go back 10 years, that we were on the brink of something really quite big happening. And suddenly you get a COVID pandemic and decades turn into weeks. And suddenly you're moving at a pace where even issues like governance start to worry you, when before I would have really been pleased if I had to worry about governance, because it meant that people were using these digital systems. And in reality, digital modalities were really not mainstream, but now they are. Even if you look at European countries again, if you look at places like the United Kingdom, originally about 10% of primary care consultations were performed, if 10%, using digital modalities. And during the peak of the first wave, it hit 86 to 90% of all consultations. So suddenly this enormous explosion in digital uptake is something we have really, really learned. This comes with problems. There are governance issues, and clearly there are training issues. The translocation of a consultation from face-to-face to digital means, as Princess Dina herself said earlier, Zoom is all very well and all these digital platforms, but nothing can actually be the same as that face-to-face human interaction. And clearly, we're all aware of that, but we need to train people how to use that. And the second really big lesson is the effect on COVID and non-COVID populations. And it was interesting to hear Elizabeth talk about that earlier in terms of cancer at Sloan Kettering, but certainly in Europe, in a few countries, this caught people somewhat unaware. Of course, all the resources of a health and care system was totally focused on managing that COVID population. But sadly, cancer doesn't stop developing. People with type 2 diabetes, people with hypertension, people with cardiovascular disease still need their diseases monitoring. And to a degree, and certainly in some jurisdictions, you saw the effect of that now feeding into the number of excess deaths associated with some of these non-communicable diseases. So that in itself is something which clearly we now have extra emphasis on actually managing NCDs in a far better way. And if there is a silver lining, and I hesitate to call this a silver lining because this is a tragic pandemic, but complex adaptive systems, somehow you always get unexpected consequences. And the unexpected consequence could well be that this is the revolution in managing non-communicable disease, and we move to a more person-focused, we even forget the word patient, person-focused, whereby we actually start to understand the fact that the medical component is only a little bit of the management of the individual and the assistance of the individual through their life course that us as people within the health and care professions are supposed to deliver. So really, that's a sort of introduction to the topic.
So thank you for that. I could not agree more with the whole person-centered focus. That is my focus as well as I build the strategy. So that I completely, cannot agree more with this. You have exposure worldwide, and you talk about how people talk about digital transformation. Where have you seen people actually using data to drive AI solutions, forward? And actually, specifically, particularly in the second wave, we've had the first wave. Now we're, experiencing the second wave in many countries. So where do you see people driving data to AI solutions on that?
I'm going to exclude the US, and not because I want to exclude the US, because Elizabeth will cover the US better than me. So I'll just put the US to the side, and I'm excluding it not because it's not important, but because somebody else will manage that process. I think the real lesson the real message to take home is that what we have seen is speed of deployment has changed. Before we talked about, we commented on, we developed processes around AI, and inevitably once the experts got hold of that, people can actually have discussions which last for as long as we choose them to last for, in terms of especially where the edges are between one bit and another bit. Of course, that's always the place where all of us enjoy having a really involved scientific discussion. But because of COVID, there was this sense we just have to deploy. And I've seen deployments, and you have to mention places like South Korea, because they love technology, they dream of technology. Sometimes I even think they deploy it because they can, even though there's another way to deploy it, but they do it in a way which is so extraordinary, not only in terms of the contact tracing processes they use, but also in terms of the way they manage their intensive care units, the way they started to play around with their digital pathways, the clinical decision support, the way they looked at their sepsis pathways and tried to play around with those to try to develop pathways for people with COVID, the way they used whatever data they had to try to develop a system whereby they understood potentially who of the patients would end up on ventilators, and so were able to deploy their resources much better. But there's one, those are some examples in the Far East, and there are others, of course. I mentioned South Korea, but actually there are quite a few other countries there that were active in this field. And now we're starting to see much more AI being introduced, particularly in terms of pathway management. But there's something which I think is a message, again, which people should retain. If one looks to which countries have been most successful at deploying these solutions, I think the more digitally mature they are, the better they will be in terms of developing these processes and deploying them. Now, you may push back on this and say, but look, countries as technologically advanced as some of the high-income countries had a pretty damn awful time in the first wave. And the answer is yes, they did. And certainly the United Kingdom, United States, France, Italy, Spain, I could go on. That is true. But I think there were extraneous factors there, and very happy to talk about those. But certainly looking at the way you deploy technology, knowing that, of course, the only way you can manage this pandemic is by a multitude of interventions in a multitude of places, by a multitude of people, unless you have a single version of the truth. And I go back to Princess Dean again, and she talked about interoperability. And unless you have a clinical decision support system which you can tweak and actually change dynamically, if you have people with cancer who have COVID, I'm sure the treatment gets much more personalized. Because of that, how on earth do you manage to ensure that people follow the right pathway? You're in a far better position to manage that process because you do that. So I think those are the really important messages around these systems and areas.
Okay, the next question is for both yourself and Elizabeth, and it's one that everyone really discusses, but we don't really have any solution at the moment. It's about trust. It's about secondary use of data. It's one of the greatest challenges, and we need to retain people's trust. And that is a fundamental issue in the present. Can you give a perspective on this?
Who do you want to start? Me or Elizabeth?
You can start, and then we can have Elizabeth join.
Okay. So secondary use of data, of course, is the big issue. It's the big potato. And it's, saying we have a solution for this, I think, is naive to the extreme. But there are some case studies. There are some places which actually perhaps teach us a couple of things about the secondary use. And I'm going to take you to Finland. Why Finland? I don't know, because Finland's a place where things happen sometimes. Finland's a place where, possibly because of its geographic location, it is to a degree somewhat isolated up there in the north, with the North Pole just above it. You can't really go very further up. It is a place where they have a long history of having developed social interventions actually to improve healthcare. And of course, we all know about the great Corelli experiments over the many, many years associated with cardiovascular disease. And that's one of the places which has the highest levels of trust between government and individuals. And even there, even in a place like that, which is small, very homogeneous in terms of ethnicity, these things are actually quite important. It took a long time and a lot of discussion in Parliament, before they got to the state where they agreed on a new policy to actually manage the secondary use of data, which led to the formation of a new institute called FinData, which really examines requests, scientific mainly requests for the use of secondary use, and then translates that and enables that to happen or otherwise. I spent a day there and it was one of the most extraordinary days, really understanding how they assess the balance between the right of privacy to an individual and the right of and the duty of the individual to their fellow citizens within a community, because in essence, that's what we're talking about in many respects. So I think there are lessons to be gained from that, but it's not quite as simple as that, because you can't drag Finland and drop it somewhere else, because it just won't look the same. These are very country specific, these solutions. There are some other examples as to the use of secondary use of data. And again, I'm going to South Korea. They have some of the strictest laws in terms of personal data in the world. But after one of their previous pandemics, they had the foresight to take a new act through Parliament, obviously not in war, but in peacetime, not in the heat of a pandemic, to suspend that personal privacy at times of pandemic, to ensure they're able to actually access the data they need to provide a really effective and intrusive track and trace system. And I mean intrusive, because personal data, social security data, health data is all pooled immediately, just like that. And clearly, something like that would not be acceptable in peacetime, but they have a sunset clause which they have introduced to actually achieve. So I think this is a very important discussion, and we haven't done very well as healthcare providers, I believe. I don't think governments have done very well globally at actually developing this conversation with citizens.
It's a very interesting topic. At NEOM, the destination of the future that we're developing, one of the elements that we look at is an opt-in society. So the mindset of the NEOMians is that you go into NEOM, or you're part of NEOM, with the opt-in, that you're opting into this data tractability, this trust. You have that mindset. But with the advent of this pandemic, this has really changed the way of thinking worldwide. And it's a question that many think about, that how do you bring that adaptability and the agility, not just in the use of data, but in the use of thinking and the use of trust? Because we have, like you said, two situations here. It's your privacy, but at the same time, it might be at the stake of someone else's life. So how do you bring that sort of medium where you can cater to both, or you develop a system like South Korea, or you develop a society like NEOM where you have this opt-in or at use urgent as needed processes. And I'd love to hear some of your, Elizabeth's thoughts as well on this topic, as this is a topic that's under discussion across the board during this time of the pandemic, and as the learnings that we learn from it as well.
Shall I see to Elizabeth, please?
Thank you. We'll consider it more of a collaboration as opposed to a secession. But this is an essential part of pandemic response, but it's also the basis of any good doctor-patient relationship. And Charles mentioned something about it. You can't just drop in a digital solution and everybody has adapted perfectly. You know, for me personally, I'm a very hands-on doctor, and you know, it's infectious diseases. We use sight, smell, all the senses to figure out what's going on. So the transition into a digital patient relationship has been, you know, vigorous and sometimes challenging for me. But the basis of it has always been trust, and the patients have to feel that whatever they're sharing with me, whether it's in an in-person consultation or in a digital one, that we treat that with the utmost respect. And I think that that has been something that a lot of direct clinicians have managed to achieve in the transition to digital visits. But on a research side, you know, there are also different ways to respond to that. And one of the things that we did at the height of the pandemic was to recognize that this was an emerging infectious disease. There is a historical legacy of people being feeling subjugated or receiving prejudice as a result of a diagnosis with an infectious disease. So there is that whole historical legacy. And from a research perspective, we were all aware of that and actually created a separate infrastructure to evaluate any studies that wanted to utilize COVID-19 data or patient data related to COVID to make sure that those got the appropriate clinical oversight, and it wasn't, and research oversight and ethical oversight, to make sure that it wasn't just a knee-jerk response. Okay, we are, you know, we're all panicked because we don't know who's most at risk. We're gonna just look at everyone's data. But we had to be thoughtful about it and had to respect the rights of patients, as well as the integrity of the data analysis process.
As we move forward, and you know, there might be a third wave. We don't know what's going to happen next. There might be another pandemic in the near future. We will keep redesigning the use of data. And just so we all have to be future-proof. We all have to be agile. We all have to think much more differently now than ever before. And as we move forward in this process, how do you see just the relationship changing between governments and societies themselves, just people and governments, even this doctor-patient relationship that you're talking about? Do you think that that has been impacted from this? And do you think that data would be much more easily usable now than ever before? Would the scope of even understanding the usage of data be changed from this pandemic? And just some thoughts around that. It's a very broad topic, but it's areas that you think are important and crucial to think about as we move ahead from the learnings that we've experienced from this. But how does that just not only redesign the way we use data, is how do we even think about data? How are we receptive to it more now than ever before as a population, as a government, as a private entity? Charles, you can start. If you, yes,
Shall I
sure.
kick off? Thank you. I think things will change really quite dramatically. I don't think we're going back to the old analog bricks and mortar type office call. You know, my father was a physician like I am. And I remember as a child watching him, he used to annotate, he used to actually try to keep a contemporaneous record of episodes of care. Which already was something really quite remarkable then, rather than each episode being just an event in itself, because of course only that way you can gain the insights to know what to do. And I think the days whereby we have the old visits, outpatient type visits, are coming to an end. They're not finished yet, but they're coming to an end as we start to develop a more holistic approach to care. Because what's also become abundantly clear is the medical component, however important it is, and I'm not for a second demeaning it, is only part, and actually only a smaller part of the total solution for an individual. because the non-health determinants are extremely important. A person having a place to live, a reasonable employment, to have enough money to be able to deliver the health and care that they need, and all the other bits that go with it, a community around them, we know are as important. I know from my history of being a physician, talking to people who live on the 30th floor of a condominium or a tower block, where the lift doesn't work, where it's difficult to get out, where you can't form relationships. Talking to somebody about the importance of managing their type 2 diabetes and their HbA1c pales into insignificance. What does that mean to them when what they're really worried about is where they're going to get their next meal tomorrow, how to manage their debt, high crime, all the other things which we know are important. So I think that is something which is clearly becoming much more focused globally. Also in the US, of course, through all the changes to Medicaid and Medicare around outcome, and where social determinants are starting to become more important. And this is where perhaps lower and middle income countries do have the potential to somersault and to avoid and to sidestep some difficulties that we have in higher income countries. Because perhaps they don't have those institutions that are so focused on medicine by body part, and can think of the whole person quicker than some other countries can. And I think despite the fact that they may not have the bandwidth that a higher income country has, their use of digital technologies already, all you have to do is go to Africa and see the use of micropayments, and the imagination with which that's deployed puts them in a position where perhaps we can be on the same footing when it comes to the next bits that we're going to develop. I'll see to Elizabeth.
Okay. I completely agree with what Charles has mentioned.
Well, we've got to try to disagree on something, so let's have a go.
Okay, well, I will disagree with the idea that we can never be future-proof against microbes. There are more of them than us, and they will always find a way. But we can be smarter about our response, I think. And I think part of that comes from a lot of the transparency that's been mentioned on this call. And that's my great hope for next steps with the digital revolution is transparency in health data. But I want to touch on something important that that Charles mentioned about, how do you talk to a person who doesn't have a lift but lives on the 30th floor? And understanding the sort of the social determinants of health, I think is actually something that nobody has focused on or really started to articulate until the COVID-19 response of as being essential to each patient interaction. And I've seen that specifically in my own practice where, I have a lot of young patients who can rapidly adapt to a digital visit. And it has been harder for some of my older patients to adopt the technology as quickly, especially those who don't maybe, live with younger family members. And I think it's, that's just one aspect of vulnerability with this transition, as well as people who don't even have access to a digital network. These are these kind of pockets of populations that maybe can't adopt all the technological innovation we're talking about today, I think are things that we need to focus on, help define, and then help bring into the next wave, which would be getting rid of my outpatient office and seeing everybody online. And I am very excited about the prospect of these digital initiatives for transforming patient care. I mean, not to sound intrusive, but it means I can follow my patients everywhere. So when I'm very worried about them, I can keep much closer tabs on them than I could with a traditional model. And so that's exciting for me, maybe overwhelming for them, but we'll work on that in our face-to-face conversations, I guess.
Elizabeth, you know, you mentioned something about older people and the digital divide in terms of people not having access. Yes, I think that the people not having access is a significant, digital poverty is a significant issue, yes. But there's something which I've learned in my work with Public Health England. I'm a senior advisor to the organization. We introduced a whole series of initiatives specifically for older people, specifically around dementia, specifically around risk reduction. And what we did is we actually ensured the language fit older people better than the language we use now. And perhaps much to our surprise, or perhaps not, we found that they were as digitally adept as anybody else. It's only that we often decide that people are 16, just out of school, or not just out of school, wearing a t-shirt, and are real sort of Gen Zs, or whatever we're calling them today, and design the processes for them and wonder why they don't apply to our grandparents. And I think if we have the right population in mind, we'll get far better at actually personalizing health and care. We are in the age of precision now. Precision medicine is what you practice. I would like to think of precision medicine having another side, which is precision health. And that precision health is not only the biomedical component, but all the other bits as well. And only by marrying those two are we going to give the optimal chances to people to live their lives to the fullest.
Yeah, it's definitely going to be based on agility. I mean, for example, one of my most challenging digital visits thus far has been with my head and neck cancer patient population, because you know, the normal ways that we communicate when we do face-to-face, well, there's often a lot of writing, which is now we chat, and we chat in the Zoom chat box while we're having our visit, and it's just about adapting to the unique qualities of the person in front of you. And I think this gets back to what Maliha has been talking about in terms of person-centered care.
Really interesting discussions here, and I couldn't agree more with precision health. That is, again, something that I've been working on, is to build in this, looking into the social determinants of health, and then blending them into a health caring system where we focus on everything. And what's interesting is that COVID has just rapidly increased that pace of thinking than ever before. So it's nice to see that everyone's now thinking on the same page, if not more than ever before. And this is a great learning for us. Even though there has been a very adverse part of this pandemic, but there's been a very hopeful side to it. And that has been the blending of the silos that existed before, and it has rapidly decreased them, which is a beautiful way to reconnect to the future and find solutions more rapidly. And on that note, I'd like to thank both of you so much for this really interesting discussion. We do have a little time left for any question or two. If anyone has any questions for Elizabeth or Charles, we're welcome to take that and have a quick discussion around that in case there is a question. I don't see any hands. Oh, I do see one person. And yes, please go ahead.
I have a question, but I don't know if I have to raise my hand first. Sorry.
It's okay. Please go ahead.
Okay. So I am Anne Arts. I'm the head of the Novartis Foundation, and I really like the discussion as well. And I just wanted to ask Charles Charles, do you have any examples of where we reached that level of precision health, or even if it's not a full example, but I would be very interested, because that's exactly what we are working on to increase the impact we can have on the health of populations with enabled by data and AI.
Thank you, Anne, and hello virtually. I haven't seen you for a while.
Yes,
and
nice
it's really nice to have a conversation with you again. Precision health, hi. Precision health is really now in the process of, being deployed. actually in quite a few jurisdictions. Let me start with the United Kingdom. At present, we are providing we have just set out an independent review of the health check. The health check is offered to every person over the age of 40 who hasn't had contact with the health system, and basically it is a cardiovascular check. But it also is a process whereby one can then have a discussion with the individual around behavior change, because in actual fact, it should be about behavior change, not a health check at all. We're moving to a new system, and I'm on the steering group with a couple of us, which is going to report back to ministers in a month or two now, looking to deploy a more digital example of that, which will also start to factor in not only the genomic data, the omics, the epigenetic, whatever you put into this, to really turn this into a very personalized discussion about risk reduction for non-communicable disease. I still have a little problem with the way we use this term, non-communicable disease, because it is non-communicable, but the behaviors are terribly communicable because they tend to run in families. The behaviors that cause it, that is. So there is an issue about the words, perhaps. But so that's an approach which we're going to be seeing relatively soon. As we use some of the genomic data, we'll have to do that. Clearly, Finland's doing something like that. I don't need to tell you. Of course they are. And even countries as far away as Japan, Kanagawa province was doing something like this in 2014, using digital biomarkers, using incentives and gamification around lower payments for social insurance when people change their behavior. So these things are around. The Danes have done amazing stuff around Copenhagen with exercise and with, there's quite a few examples appearing. If you're asking me, is there data to support their use long term? Then I'm in difficulty because there isn't yet. But I think it's clearly the direction of travel. How can you deploy precision medicine effectively unless you deploy it on the right people? So, you know, it's obvious this has to happen.
Thanks a lot. Yeah, I cannot agree more. This is the way forward for having an impact on the health of a lot of people. But thanks, Charles, and great to see you.
Well, thank you, Anne. Does anyone else have any questions for Elizabeth or Charles?
I can ask a quick question. Sorry, I couldn't figure out how to raise my hand either. Okay. Probably question to Elizabeth. So we focused quite a bit about all the innovation and good outcome that had already come out of the COVID pandemic, and how we learned how to use data better, faster, how we figured out supply chains and all these good things. But nobody mentioned about the other impact of COVID-19 response, such as impact on medical care outside the COVID. That is, for example, I'm driving to my office this morning and to log on this conference, and I hear a report from the Gates Foundation published today, I think, or to be published today, about global vaccination that had declined from in children from about 85% to about 70%, and the potential impact of having these millions of children who are unvaccinated at this point. So, I mean, a few comments about the other side of the response to COVID. When does the response to COVID or the desire to control the pandemic may compromise health otherwise?
I think that's a critically important question. Thank you for raising it. I can tell you that when you're involved in medical epidemiology at a cancer center and you try to reduce activities directed towards cancer care to respond to a pandemic, you get a lot of questions exactly in this vein, because for oncologists, you know, it's not just treating the patients with cancer, but it's diagnosing those in early stages. And I think that's been something that we've all been sort of on pins and needles about. What will this disruption in screening and delays in screening, for example, annual colonoscopies were really suspended in March, April, and to some degree in May, for patients who weren't having active symptoms. Does that mean that in 2021, we're going to see patients presenting with later stage disease? I don't know that we know the answer of the true impact of this yet, but it is definitely on everyone's mind. And you rightly point out the critical question about pediatrics. Vaccination rates, especially in areas where vaccination coverage was maybe threatened by anti-vaccination movements, those have also taken a significant hit. We all hope, I think, in the infectious diseases world that with the coming of influenza season, when people present for their flu shot, they'll be able to do some catch up on anything that was missed or delayed. But I don't think we know the impact yet of these delays. And I will say that this is not a question that most of us just started thinking about. At the moment that we were talking about reducing access, because we had to use ORs as potentially ICUs, we were already thinking about the restoration plan. And I think that was true of a lot of my colleagues at other institutions who weren't dealing just with cancer patients.
Thank you.
If I may just interject here, because I think that question is particularly relevant. The non-COVID populations, which we alluded to before, includes vaccinations, includes even things as simple as smear tests in affected populations were suspended in some countries during the COVID pandemic. Now, clearly, this is something which is going to have a very long tail in terms of the effect. We're not going to know what the effect is for some number of years. And I'm absolutely sure it's not going to be a positive effect. Or if it is, I would question what the hell we've been doing over the last 100 years being physicians, because we clearly haven't had an effect at all, or even worse. So I think we're going to be seeing adverse effects for some time. We know there have been significant effects upon people. If we look at non-communicable disease, a lot of clinics, for example, for dementia, to assess dementia, practically closed down during the first wave in the United Kingdom. In England, there were only about 16 consultations in a month. I mean, this is unheard of. It should be about 100 times more than that, at least. Because everybody stopped. People haven't got, people died at home from their myocardial infarctions because they didn't want to call an ambulance. Some of them were scared they'd actually get nosocomial infections in hospitals. There've been enormous effects we still haven't quite understood.
Yeah, making people understand that it is safe to get their care has been a real critical part of our restoration plan. Especially for oncology patients who are incredibly risk averse as a population. Thank you for that question. It's a critically important.
Thank you.
Great, thank you. We have 2 minutes left. We just had one quick question, and it was really for all the panelists, but I can take that question, and if Charles and Elizabeth have anything around that question as well. So Bishop Aubrey Harley. And the question is, what is the food industry doing to make their products healthier? And it's a different type of question, but it's an interesting question during this age. What I can talk about as a very quick note is that we are going to be installing these their health-caring platforms in our community that actually have a virtual check-in for all the NEOMians. And what we do is we talk about how do we cater to their personalized food preferences, and at the same time make it healthy. So if you do have a chronic illness and you are trying to maintain a healthy diet, you talk about your habits, we take that data and we make a personalized program, food program for the whole week for you. So I don't know about food industry per se, but as an institute, as a destination, what we're doing is we're creating health platforms that take the data in of what you eat every day and try to give you healthier options and personalize it according to your needs. So I don't know if that answers your question fully, but I think it sort of touches on what can we do now to make, even in terms of many things across, just, you know, taking care of yourself. It's beyond just what you eat. It's also about what you do, how you take care of yourself, but food is a huge element of how you take care of yourself. So from a company or a destination perspective, we've tried to make it healthier through personalizing the food programs. If you have anything to say, Charles or Elizabeth, in terms of anything that HIMSS might be doing.
Just a very quick intervention. I mean, in England, of course, we introduced the sugar tax. So we have a direct influence and have had direct influence on food manufacturers and food. Of course, food is part of what we do. It has an integral part, as you identified, in terms of health and care. I think what we can do is actually sensitize the population to the importance of food and let the market do the rest. Because the moment one food manufacturer makes the changes, the others will lose market share if we're smart enough to sensitize the population appropriately. This is a continuing campaign. We're just starting. This just goes on.
Absolutely. Well, thank you for these questions. And since this was such a different question, one thing that it talks about or touches on is a different way of thinking. Because if you think about food, the data that you collect for the type of food you eat and how much healthier you can make it can also make you less vulnerable to pandemics like COVID-19, because it does touch much more effectively on how you take care of yourself, but also if you do have a chronic condition, it makes you that much more vulnerable. So thank you for that question, and thank you for this great discussion. I love the way it's so diverse. It just showcases how we can rethink not only data, but how we can rethink the way we're going to design the system moving forward after this pandemic. So thank you, everyone, and we'll move to the next session. Thank you. Bye-bye.
Thank you.
Thank you, Dr. Hasmi. Thank you, Elizabeth. Thank you, Charles. I found it fascinating as well, and certainly a wonderful way to launch the summit.